Okay, let's get started. So recall tomorrow we have our lab quiz over the lower limb.
Wait, what?
Oh wait, yeah. And then after that, Dr. Carlson will be here to talk with us about clinical applications of the anatomy of the limbs. So make sure you stick around for that. We should be pretty good. So today we'll start the upper limb. I'm going to do an overview lecture like we typically begin our sections with. These are some of the high points of the chapter. So if you get nothing out of the chapter but these points, you have to get these ones. Okay, these are really high yield, is what they call. So they're things that show up on like PANCE questions quite a lot. Things that you'll see in the clinic. So these are very relevant. The most relevant issues of the chapter. So make sure we really get these. Okay, so we'll start off nice and easy. The regions of the limb, the upper limb. So we start off with the shoulder, obviously. And I just want to point out the name of the shoulder joint is the glenohumeral joint. Down below the neck of the humerus, we have the arm. And so, in vernacular, typically we think of the whole limb as the arm, but really the arm is only the section between the shoulder and the elbow. The portion between the elbow and the wrist is formally called the forearm. And then obviously we have the hand at the end. The connection of the upper limb to the rest of the body is achieved through the shoulder girdle, and that is composed of the clavicle and the scapula. So these make up the shoulder girdle. There's a space that runs in between the scapula and the clavicle, and then down through this portion in front of the humerus and behind the pectoral muscles, and this is what we call the axilla. This is important transition point. Okay. So then we'll move on to talking more about the axilla. So you see it here. This is the region where all structures passing from the thorax or neck into the upper limb, this is the avenue through which they pass. Okay? So, their passage into the upper limb. Like I said, it starts, the inlet is at the level of the scapula and the clavicle. Its posterior border is the scapula itself, and then the proximal part of the humerus. On the anterior border, it's those pectoral muscles, and then the medial border would be the thoracic wall there. So that kind of pyramidal shaped region. Okay. So that's one of our points of transition. We have another couple, the cubital fossa. So this is the anterior surface of the elbow joint. And this is one of those locations where also the neurovasculature is near the surface. So that gives us access to those structures at that point. Also, it makes them vulnerable to damage when there's an injury to that region. And then finally, we have the carpal tunnel, which is on the anterior surface of the carpal bones. And the anterior border of it, so on the roof of it is the flexor retinaculum of the hand. So anterior. Can't spell today. Carpals and flexor retinaculum. Okay. So these are the three transition areas between the different regions of the arm. The only one that really gives us good access to the neurovasculature is the cubital fossa. And as we all know, that's a location common for blood draws, etc. Okay, so then, like we had at the beginning of the semester, we have movement terms. Most of these we're pretty familiar with, so I'll just point out a few that tend to be a little more confusing, maybe less familiar with. So as the arm is abducted and adducted, the scapula rotates. So we have, let's not spell rotation. Rotation of the scapula. Without rotation of the scapula, there's actually only about a 90-degree range of motion in the arm. So it can only raise about 90 degrees. Anything above that, it has to involve scapular rotation. So it's pretty important. Yeah, question?
Can we go back to the previous really quick?
This one here?
Yes, so you're saying that the anterior flexor retinaculum.
Mm-hmm.
Okay.
Yeah, so the anterior surface of the carpal bones and the
I
flexor.
heard next time. No, you're good.
Okay. All right. Any other questions? Okay, so rotation of the scapula, important for extending that movement of the abduction of the arm above 90 degrees. And then we have protraction and retraction of the scapula. This is moving it away from for protraction and towards for retraction the midline. So moving it away from and towards the midline. Anybody remember the muscle that is important for protraction of the scapula? Way back at the beginning. Okay, no, protraction, so moving it forward.
Oh, protraction.
Serratus anterior. That's that one. It's important. So it attaches to the medial scapula, comes and wraps around, attaches to the ribs. It was a long time ago, that's why I brought it up. Okay, retraction would be the rhomboids. That's one of their major functions, yes. Okay. All right, shoulder joint. So the shoulder joint is the most mobile joint of the body. So it has the greatest degree of motion. So we've got all kinds of different movements we can have. We can have the flexion and extension, abduction and adduction, medial and lateral rotation. You guys should be fairly familiar with these. I don't need to belabor them. And then we have circumduction, which is that combination movement of flexion, extension, abduction, adduction as you're moving your arm in a circle. So circumduction. Okay. Those ones are pretty easy. For the elbow, we just have flexion and extension. Remember, it's a hinge joint, so it only has one axis of motion, so only two potential movements. And then for the forearm, we have pronation and supination. So remember, in anatomical position, the palm is facing anteriorly. To pronate it, we rotate the palm posteriorly. That involves rotation of the radius in its articulation with the humerus. And then supination, moving the palm back anteriorly. One way students in the past have remembered at supination, you can hold a cup of soup. While pronation, you pour it out. Okay. That helps.
Can you say that one more time, the pronation, supination? So this
Yeah, so supination, you can hold a cup of soup. Pronation, you would pour it out. Okay? Helps me. Okay, wrist joint. Again, most of the extension and flexion's pretty easy. Abduction and adduction, and this goes back to remembering what anatomical position is. So remember, anatomical position, the thumb is facing laterally. So abduction of the wrist would be moving towards that thumb side. Adduction would be moving towards the pinky side. And then we have circumduction again here. As a combination of the four movements. Okay. All right, the digits. So like we had in the lower limb, abduction and adduction of the digits is in relation to one of the digits. However, this time it's in relation to the third digit instead of the second digit. Okay. So adduction away from the third digit, adduction towards the third digit. And the third digit itself is laterally or medially deviated. Okay, and then of course we have extension and flexion of the fingers, so the digits, and that can happen at any of those joints within the digits, so the metatarsal phalangeal joint or the interphalangeal joints. Okay. And then finally, we have the thumb. So the thumb is kind of non-intuitive in its movements. So extension and flexion. So extension is moving the thumb across the plane of the palm. So you can see flexing those joints. I can't do that independently of my finger. Maybe this side will work. There we go. Okay. And then extension would be moving the thumb away from the palm. Abduction and adduction. So abduction would be moving away from the plane of the hand. So the plane of the hand is this plane here. Abduction moving away from it. Adduction moving it back into the plane of the hand. And then finally, opposition of the thumb is a combination movement where we reach and touch the tip of a finger. So it can be any one of the fingers. This is all opposition of the thumb. This requiring both abduction and flexion. Okay, so that's opposition. The opposite would be reposition of the thumb. So that opposite movement, bringing it back into the plane and out away from the palm. Okay, those clear? Make sense? Yeah.
I don't know if this really matters, but at what point is it considered, so this is extended, is that like hyperextension?
Mm-hmm. Yeah, so it would be
When you go
hyperextension, would be anything back beyond the plane of the hand. So. Good. Excuse me. Any other questions? Okay. All right, so bones of the upper limb, this should be another easy one. So obviously we have the scapula and the clavicle contributing to the shoulder girdle, the humerus of the arm, the radius and ulna, the forearm, carpals, metacarpals, and phalanges of the wrist and hand. So that should be a nice easy one. All right. So here's some muscles coming back to haunt you from earlier in the semester. So superficial muscles of the upper limb. So these muscles, though they're located on the thorax and the back, are actually, their action is to move the upper limb, so that's why we have to talk about them again. So remember, we have the trapezius, and remember to note that the trapezius can move, contract in several different regions, so it's not the type of muscle where every part of it has to contract. When the muscle contracts, it can contract just these upper fibers or just these lower fibers or combinations of them. And this can cause several different things. So it's not only can cause like scapular depression, it can also cause scapular elevation and rotation. So it's involved in all of those movements of the scapula. And then we'll get into that in more detail. Remember, the latissimus dorsi is important for extension of the shoulder joint, medial rotation, and adduction. And again, we'll get into this more later. The rhomboids, rhomboid major and minor, involved in retraction of the scapula, and levator scapulae would be elevation of the We also have the deltoid muscle. So that's the muscle comes down, covers the superior and lateral portions of the shoulder, involved in abduction of the shoulder joint. Yeah, that's all I want to mention on this one. Okay, so remember those muscles. Should be easy. Okay, here's some additional muscles, superficial muscles, and these all together, their tendons compose what we call the rotator cuff. Goes the tendons. Okay. So we have 4 of them. We have the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. These all originate on scapular features and then attach to the humerus. And their function as a whole is to pull the head of the humerus into the socket. And the socket's called the glenoid cavity. So when those muscles contract, they're actually actively pulling in the humerus into its socket and preventing dislocation. Excuse me. These are all kind of packaged in a tight area, so inflammation of these, the tendons, often cause quite a lot of pain. Damage to the tendons is a very painful injury. Yeah.
This isn't the next teres major. Is it?
It's supposed to be minor. I don't know what I was writing. Thank you. Teres minor.
So those are tendons and not muscles.
No, these are muscles. They're tendons, so you can see the tendons here, and then there's longer tendons of the ones underneath. The tendons are actually what compose the rotator cuff. It's proper. These are just the muscles contributing to tension of the rotator cuff.
But their actual tendons make up the rotator cuff.
Correct. Okay. Any other questions? No. Okay. All right, so compartments of the upper limb, nice and easy. We just have anterior and posterior compartments of each of the regions of the upper limb. So here we go, anterior and posterior of the arm. Anterior is predominantly flexor, posterior is predominantly extensor. Same thing with the forearm. Anterior is predominantly flexor muscles, posterior is predominantly extensor muscles. Because we only have 2 compartments and we have a whole slew of nerves that go to the upper limb, we can't say the rule of one nerve innervates one compartment. There are some compartments that are innervated by a single nerve, but there's some that are innervated by multiple nerves. All right, so relationship of the upper arm to adjacent regions predominantly is movement of structures from those regions into the upper limb. So we have structures moving from the thorax, and these would be the major arteries and veins. When they are in the upper limb, we cross over into the axilla. These are the axillary vein and artery. Before that, so in this region, what are their names? Subclavian vein and artery. Okay. We also have all of the nerves to the upper limb coming from the cervical and first thoracic spinal nerves, all coming down and composing the brachial plexus as they move through this axilla. Excuse me. Okay. Thoracic outlet syndrome. So this is a problem where we have constriction of this the region through which these structures are moving. So this is actually called the thoracic inlet, but it's the thoracic outlet syndrome. Just to confuse you guys, you know, you got to make it harder on you. But what happens is there's some sort of a narrowing of the thoracic inlet, Very often this is due to the presence of cervical ribs. Remember, we can have extra ribs coming off the cervical vertebrae. And that'll narrow this outlet and actually cause some impingement of these vessels and of the nerves. And so the result is you can prone to get tingling and some numbness in the upper limb, not getting sufficient blood supply. Okay, so that's thoracic outlet syndrome. Excuse me. Okay, we good? All right, so relationship of the breast to the upper limb. So remember, the breast sits on top of the superficial fascia in the pectoral region, but we have this extension of the breast, the axillary process, that moves into the axilla. So actually moving into the regions of the upper limb. It is important because often with self-breast exams, people forget that axillary process exists, so they might overlook a problem. Thankfully, practitioners don't usually do that. So it's just for the self-exam that's the problem. And also remember that this portion of the breast is drained partially by the axillary nodes for the lymphatic system. So you can get metastasis of breast cancer into the axillary region as well as into the pectoral and thoracic regions. Okay. All right. So overall innervation of the upper limb. So like I said, we have the anterior rami of C5 through T1 that all interconnect to form the brachial plexus. And this brachial plexus we will get to know very well. For this lecture, we'll just introduce the four main nerves of the brachial plexus: musculocutaneous, median, radial, and ulnar nerves. So again, we'll get to know these well. Just want to introduce them. And it's important to remember that, as always, we're dealing with the anterior rami of the spinal nerves. Even when dealing with some of those superficial muscles of that are on the back, it's all anterior rami, because remember, posterior rami only innervate deep muscles of the back, right? All right, so then the dermatomes of the upper limb. So as with the lower limb, it's important to know these dermatomes. So be able to recognize them, be able to identify the dermatome affected if I give you a particular set of symptoms of loss of sensation. Also, really important to remember are these autonomous zones here. So remember these little bullseyes for the autonomous zones. Do you remember what those zones are for?
Like if you stimulate, you know you're getting that one region.
Mm-hmm.
Rather than overlap.
Absolutely. So those are regions you can use for stimulation tests, and you know you're testing only that single dermatome. So you need to know the locations of each of these autonomous zones as well. Similarly, we have our myotomes here, like we had for the lower limb. And so again, know the action that is caused by each one of the spinal nerves. So say abduction of the arm, predominantly C5 has the fibers that are contributing to that. And then again, like the lower limb, we want to be able to relate that then to the muscles and to the nerve that those fibers are running in. So use this slide to help you kind of put all that information together. And like I said, last lecture, some really good test questions. Okay. So then back to our four major nerves and what they actually innervate. So musculocutaneous nerve, thankfully, is the one nerve that innervates the anterior compartment of the arm. The radial nerve innervates the posterior compartment of the arm and also the posterior compartment of the forearm. And then we have the median and ulnar nerves that innervate most of a certain region, but there's a bit of crossover, so make sure that you learn those. So median nerve flexors of the forearm, so that would be predominantly anterior compartment, and thenar muscles of the hand. So remember, thenar is this region here. This is our thenar eminence on the thumb. This is the thenar region. Thenar is a old Greek term that means palm or sole. So, but instead of the whole region, we're just talking more the eminence right at the region of the thumb, typically. And then the ulnar nerve, most of the rest of the intrinsic muscles of the hand, as well as some of the forearm muscles. For the cutaneous distribution, just be mildly aware of the fact that there's a pattern of cutaneous innervation. We won't really emphasize that so much. At some point you may have to learn it, but not for this class. Okay? All right, so then like the lower limb, we also have some close associations of the nerves with the bones, and that would then be potential sites of nerve damage when we have fracture of those regions of the bone. So we have the axillary nerve, which is a tiny little branch of a nerve coming up around the neck of the humerus. We call this surgical neck of the humerus. So any of those fractures up high on the humerus could potentially damage the axillary nerve. On the posterior side of the humerus, there's a groove called the radial groove, and the radial nerve runs right in that. And so mid-shaft fractures of the humerus often are associated with radial nerve damage. And then finally, the ulnar nerve runs right on the posterior side of the medial epicondyle of the humerus. So this is the region we typically call the funny bone. And so then any fracture of the medial epicondyle, kind of fracturing this region, potentially damage the ulnar nerve. Okay. All right, and then finally, superficial veins of the upper limb. So we have the veins beginning with this dorsal venous network of the hand. And the two veins that come out of that are the basilic vein and the cephalic vein. The cephalic vein is the longer of the two. It travels up the limb and dives deep at the clavipectoral triangle to join with the axillary vein.
What triangle?
Clavipectoral, right here. So that's just underneath, just inferior to the clavicle. The basilic vein actually continues on and changes name as it reaches the axillary region and becomes the axillary vein. So basilic vein and axillary vein is just name change there. And the name change happens at that end of that axillary region. Huh?
Brachial?
Nope, basilic. It's brachial artery, basilic vein.
Your brachial vein is your deep vein, your superficial.
Yeah, these are the superficial veins. So this is this.
Basilic doesn't change names, it joins into the axillary.
Then your textbook is wrong.
Well, I mean,
It turns into the, that's just.
yeah, that's just where it jumps in.
Interesting, okay. They lied to me. Okay, well, anyways, it dumps into the axillary vein. Okay. And then finally we have the median cubital vein, which is a branch of a vein here that kind of connects the cephalic vein and the basilic veins. And that happens right at that cubital fossa. Well, I'm gonna have to get out Gray's Anatomy and really dig into this. Can't believe it. Okay. Any questions about any of that? Pretty straightforward.
What does it mean when it says loss of inter-individual variation?
Oh yeah, well, I forgot that on the notes. So superficial veins, you typically see quite a lot of inter-individual variation. So they go crazy. They just do whatever they want.
They're just in different spots? Or?
Yeah, they'll have different branching patterns, be in different spots. Not what we expect. Deep veins and arteries are less likely to have that kind of inter-individual variation, and nerves almost never have that inter-individual variation. So just to be aware that these superficial veins may not look like what we are learning. Okay? Any questions? Okay, so don't forget quiz and guest lecture tomorrow. Enjoy your afternoon.